record, put the recording in the announcements, usually by the next day. And I also will attach the PowerPoint again. So you'll get an announcement next Sunday with the PowerPoint. And I also, after the recording, put it there just to make sure that you know where it's at. It's like a double, making sure that you have it. Because I have students say, oh, I didn't see the recording. So if you're listening to one of the recordings from one of the lectures, then you do have the PowerPoint that's there. So welcome to pediatrics, and you should be proud of you all for just getting here to this point. You're at the the other hump. You're over the hump now, going towards the end of the program. It does get a little bit crazy and hairy at this point, especially if you do have those 3 classes together. And I know it's rough. I send out an announcement every week to let you know what's due. The one thing that I appreciate from you is if you're having any issues. Let's say your kids are sick. You can't get to an assignment. Something's happening. You're sick. You're supposed to take an exam. You can't. Let me know beforehand, and we can work together in making another arrangement for you. My goal here is to have you pass. It's not to try to do everything to fail you, okay? I am here as your mentor, as your guide, as somebody that's, if you don't understand something, please just reach out to me and I can explain it. You will see as I teach very simplistically. I don't use big words and terms. I explain them, bring it down to earth, and I'm going to use a lot of examples from many, many years of experience that I have. I literally graduated nursing school in 1976. So it's a long, 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 long time ago. And I've enjoyed every single moment of it. I have worked in the adult world, and then I switched in the 90s to the pediatric world. I have done mostly the ICUs, telemetries, ER. My favorite of all favorite is pediatric cardiac intensive care unit. I love the heart and I love the way it works. And you're going to see that when we get to that week 5, which is cardiac respiratory. But I can make it that you understand it if you listen, and then take the recording and listen again. So it's a hose. It's a garden hose with a kink. And if you can think of that, it makes it a lot more simplistic, as long as you know where the anatomy is located. Back in 1976, I graduated. I went out into the world and did all my adult worlds, and I had an associate degree, just like you all. And in 2009, I decided, I've always wanted to continue my education. So I went back to school, got my BSN, got my MSN, and I am now in the process of finishing my PhD at Barry University with a pediatric dissertation. Only one of 2 that they've ever done there. They're mostly adults. And my dissertation is school-age children's attitude and behavior towards injections. Because when you're a child who's afraid of the shots and needles, you become the adult with needle phobia. And especially today, in today's, what's going on out there, you need to get an injection for immunizations, right? And there's many adults who won't because of the needle and that fear. The one thing that we've never done is we've never asked a child, why are you afraid of needles, injections? What was it? Or what made you not afraid? We have assumed, we've distracted, we've used numbing creams, jellies, played music, played games, done all of this stuff, but no one's asked this school-age child. And it is a great population to ask questions. So that's what I am in the process of finishing up right now. I've done all the coursework. I'm just now, with COVID, I was put on hold. So now I'm just getting back and finishing it up. So I really love pediatrics. Today, what we're going to do, and I'll tell you the beginning of every class, we are going to be doing, I introduced myself. If anybody has any questions, always stop me. Don't feel like you're rude, please. You don't know something, put your hand up or just say, Professor, I don't understand that, because I'm sure somebody else doesn't either. I'm never offended, because if you don't know the answer to the question, I want to answer it for you, okay? Today, we're going to be doing, number 1, going over the rules, the regulations of online pediatrics and what my expectations are. Then I have a PowerPoint that I just posted up there for you. And I'm going to be doing a Kahoots. Now, these Kahoots are very important, and I was explaining it to those earlier here. They're very important because they do cover a lot of concepts. I don't just pull questions out of the air. I thoroughly think about what I'm pulling out because I know that they're on exams. I know they're on quizzes. I know they're on HESIs. So one of the studying tools you should use is the Kahoots. Go back and look at them, okay? Very important. And if you don't understand what the Kahoot says, open your book. The book, you know, sometimes it's a little bit intense to read, but if I've given you a question, you can go back and look and go, oh, now I get it. Now I understand it. There's a student trying to get in and her name is Aliana. Did somebody just send that to me?
I did. She texted me and told me she's been trying to get in, but it's not letting her connect.
Okay, because I did not block anything. So does she have the right Zoom number? 394-747-1606. Have her try again because I have no block on it for, you know, I didn't shut the classroom, okay?
Sometimes when you start recording, it locks people out. It happened last quarter.
Oh, yeah. All right. Because I've had no problems coming in and out before. All right, let's see if she does. If not, I'll stop and continue recording. So let's go now. Let's go to our screen. Let me know, okay, Allison, let me know if she can't get in. And then I could just, Tiffany, right? Tiffany. I will turn off the recording and turn it back on if I need to, because I don't want anybody locked out. So let me get my PowerPoints up. 1 second. Any questions so far?
Where did you post this PowerPoint link? Because I don't see it in the chats.
It's in the chat.
It's in the chat.
And this one here that I'm doing is the one that I put in the announcement. Is just the orientation to pediatric nursing and online nursing.
Okay, thank you.
No, you're welcome. I'm sure somebody else couldn't find it either. So online nursing, you know, on online courses, you know, this is a very different way of teaching. Usually online is you read something, you write something, the professor writes something, and there's no meeting and greeting, but it's a very unique way of teaching. And actually, I really enjoy teaching online. I actually get to learn a lot about all of you, even in an online forum. So always be willing to share with me because, you know, I'm here, of course, to help you. So online, we know online, you must come to class every week, okay? Remember the courses, when you have any homework, it opens Sunday night at midnight, well, Saturday night into Sunday midnight, and it's open till Sunday 11:59 p.m. Eastern Pacific time. So in Eastern time, you've got an extra 3 hours right now, okay? So to let you know is I am the lead pediatric instructor. So usually they say, go to your instructor, go to your lead, and then you can go to the dean of any problems. Now I want you to know that Dr. Brown is a very, very accessible woman. If I can't get you what you need, I encourage you to go and send her a message, and she responds very, very quickly. You'll also notice that I don't wait for 24 hours to get back with you. I have my phone connected and I'm always looking to see, like every hour I'm looking to see, is there any questions from students that I can help you? So I really give pretty quick feedback for you. But this is her phone number and this is her email in case you have any questions, concerns, anything. So whenever something goes on, I always encourage you, get with me first if there is a problem. For instance, let's say you were taking your quiz and there was a thunderstorm and your computer went out. By the time you went back, the quiz was already timed out. Let me know immediately, okay? And then I can do a reset on your quiz. So what I'm telling you is good communication. It behooves you to communicate with me because I can help you. If you don't talk with me, you don't communicate, I don't know what's going on in your life. You need to let me know. I do have some times with how to reach me. I usually will not answer after 8 or 9 o'clock at night. Usually I'll start answering about 10 o'clock in the morning. And I will answer all day long. Now on the weekends, I usually will answer all of your emails also, 12 to 6 for sure. And just reach out to me and I will get back to you, whatever your concern is. As I said, it starts at 12 a.m. It goes to Sunday, 11:59. You do have a discussion question. The first post is due by Wednesday. Now, one of the things I want you to know about discussion questions, they must be done APA format. Some of the things that I find students don't do is during the middle of it where you're describing a condition, you need to cite a source. Just put a citation in there. Just because you put it as, your reference, it doesn't mean that it's, applied to what your post says. So just put somewhere in there citing the source. And if you have trouble with that, you just let me know and I can help you. Make sure that you do not cut and paste, that you use your words because we're trying for you to understand. If you're cutting and pasting, you're not going to understand what those words mean. Now, one of the things about online is you're going to see the students who do not post in their class for 14 consecutive days will be dropped. And you'll be dropped without warning, which means this. At the end of every class, I want you to sign your attendance attestations. That's 1 point of contact. You need 2. The second one this week is going to be your discussion question. So make sure that you do the work when you're supposed to and have 2 points of contact, because that's the only way we can show that you are participating and attending. So you'll see me say, hey, please sign your attendance or please do your discussion question. It's because I'm telling you, hey, be careful. I don't want you dropped. Okay, that's why I do that for you. So as I said, you are going to be into a lot of work, especially you're into those 3 classes, the community, pediatrics, and med-surg 2. Most of you are, some of you aren't, but most of you are. Make sure that you know exactly what is due when, okay? I tell you with pediatrics, the way the students do the best, and they've told me, is at least do that interactive PowerPoint before you come to class. That's the first time you see the information. Then I'm going to teach it. That's the second one. And then you're getting a quick quiz exam type right after with the Kahoot. So that's 3 points of reference that you will see this information and it's going to stick. You're going to understand it so much better if you've done that one extra. At least do the interactive PowerPoint. I know it's hard, but that is going to help you succeed in this, okay? The anything that's due, I do put it on your announcements every week so that you know. Also, it's in your calendars. Make sure that you keep up with the work. I do have to let you know, case studies are open and closed on time, okay? But the Kaplan, the NCLEX questions discussion boards are open. You can post them when you want. Because I know some of you like to work ahead, but I don't do case studies ahead. But Kaplan, they're open right now. You can go to them, okay? As long as you can, now make sure you go through the modules. If you don't go through the modules, you get a 0, okay? Especially with case studies. And then that's your one try. You'll get it. And every single case study is 1% of your grade. So it can be significant in the end. So make sure you go through those modules, okay? Quizzes, your first one is next week. This semester, we've changed all of our quizzes, so they're all new. I will review a lot of this information during lecture next week so that I know that you're going to see it. And I usually will tell you, do not do that quiz until you come to class so that we can look at it, review it, so that you know that you understand it. Because I want you to succeed and I want you to get those hundreds on all those quizzes. As I said, please talk with me. I have students that text me. If you want to text me, it's because I'm having a heart attack. I'm having a moment. I need to know now. Okay, text me and I'll get back with you. If it's something that can wait an hour, 2 hours, or maybe overnight, send me a message in Canvas. I'm telling you, I do get back very, very quickly. So just to let you know, make sure that you keep up with the work. Don't wait till Sunday night at 11 o'clock to try to get things done. I know you're busy. I know there's 3 classes. Many of you work full time. Many of you have families. I get it. I understand it. Just try to keep up with the work and you'll be good. Again, if you fall behind, something happens. It can't be all the time, but let's say 1 week, it was just one of those weeks. Let me know. I can give you a day or 2 to finish things up. You gotta just let me know. Make sure you have the syllabus. Make sure that you know when things are due. I mean, I print everything out. Some students like it all, on the computer, virtual, that's fine. I like paper. I like to check off and put colors and whatever I need to do with it. So whatever works for you, the syllabus is exactly what this program is. There's no changes in there. Make sure you have your textbook. It's the same one as OB maternity. And we start at chapter 26. I do have other sessions. Let's say you got a doctor's appointment today and it took you, 3 months to get it. And it's today during class time. Let me know. I have 4 sections this semester. I can let you come to another section so that you can get it fresh and you can get it live. Okay? If it's something you can't do, missing 1 class, okay. 2, no, okay? So just let me know, we can work together. Also, I have other professors that are teaching. There are right now a total of 10 different classes, so we can put you in somewhere. So this is the way we grade here. Now, the objective grades are unit exams, quizzes, and the HESI, and that equals 80%. The other stuff is divided by the stuff down here. Now, if you see this pediatric assessment or Kaplan, we're not doing Kaplan this semester. Kaplan is gone, okay? We're only doing the pediatric assessment. And if you look in the module, all your information is there, but I will be discussing that. I would advise you to try to do it early, okay? Try to get that done early instead of wait until week 7 and 8, because community has stuff done there too. So I would start to think about, and this is what this assignment is about, pick a child, virtual, or somebody you know, and with a diagnosis that you want to know more about. It could be something as simple as asthma. It could be something like cerebral palsy, seizures. Could be a syndrome like Pierre-Robin or DeGeorge. And what you're doing is a 3-component thing. One is only a 250-word APA paper, very short. Just describe the condition to me. The second thing is a assessment. And on the assessment, please don't put not applicable, because everybody has a heart, everybody has a lung, everybody has an endocrine system. You need to write something in every different section. And then the third thing is you're going to do a teaching tool, whether it's for nurses, and I've done them for nurses before, or the patient, the child, or the parents. Teach me something about whatever condition it is. If it's asthma, maybe you teach about the triggers or how to give, an inhaler, how to do it. But a brief, it could be PowerPoint, picture board, or a brochure. And the PowerPoint 5 or 7 slides, it doesn't have to be crazy, but teach me something. I've done it for nurses in the past where they had new diagnoses on different syndrome that they didn't know about. And one of my students actually did one on that syndrome, and we actually lectured the nurses when I was doing the on ground. I used to be on ground when we were at clinicals, and it worked really well. So it could be for whoever. So that's coming up. And then of course you see the rest.
Professor,
Yes,
sorry. When is this due?
I believe, let me see. It's due March 6th.
And that's the pediatric assessment?
It's a pediatric assessment. You choose a child, your age, could be somebody you know, your neighbor's kid, your friend's kid, could be you as a child, but give me a pediatric age and some sort of diagnosis that you really want to know more about.
Okay.
I've had students take their husband's brother, different things, and they really enjoyed it because they got to learn more about something that, is in the family or with a friend. So make it fun, or
Okay.
pick something that you really don't know about and you want to know more because you need to know it for the exam or for the HESI or the NCLEX. Okay. So we know that you need to have a 78.0 on the objective scores before we add in subjectives. I will warn you, we had 3 students fail because of subjective grades last semester. They had a 78 in the course and they failed the course because they didn't do all of these subjective grades. I will let you know when you don't have it there. Hey, did you forget? So if something is due Sunday, okay, let's say this past Sunday, the 9th of January, it was due and you didn't do it. You have 1 more week and 1 more week and it will be minus 10%. After that 1 week, you cannot do it again. It is done, it's gone. Those percentage of points are gone. You can't get them back. You can't go back to week 1 when it's week 8. We do not do that. Quizzes, they are timed. Remember, as you do them, you can't go backwards. So make sure that you know what answer you want. Each quiz is 15 minutes, okay? There are 10 questions in every quiz. It was a little different in the past, but now there's 10 questions on every quiz. And once you click it, you cannot go backwards. And make sure you submit it. If you're looking and you don't know if it did, send me a message and I can go back and I can look. Or as I said, something happened, internet something, let me know. I can go back and actually see timestamps. I can really investigate it really well and I can validate what you're telling me.
Quick question.
Sure.
Sorry, it's a little off topic, but I guess next Monday, our teacher told us that it's a holiday and we don't have class in school. Do we still have lecture on here?
No. And what I will do is I will send you the information.
Will we still have the quiz for that week?
The quiz is still there. The quiz
Okay.
is still there. But what I will do, I will send you a recording from another class so that you will have the information. But no, you don't. It's Martin Luther King. You don't have to. Okay?
Thank you.
But no, thank you for letting me know. I forgot to tell you that. Exams are done on ExamSoft via Zoom during class time. Okay? If you are that person who cannot do Zoom and you cannot, that unnerves you to do it, make arrangements with your campus and just let me know you are doing exams on campus. I know Centerville, Cookville sometimes does it. They'll set up rooms for it. So just, plan for it. Our first exam is week 4. Week 4, week 7, week 10, okay? Again, anything, contact me. Good communication, it behooves you. Your homework assignments, again, make up your schedule, write everything down, you know, or make yourself some sort of spreadsheet, you know what's due when, whatever works for you, please. You know, I like having my little calendars and I write things on them, whatever works, make sure it's done. Any questions with any of this, please let me know. NCLEX questions, they must be submitted in the proper format, okay? If I'm seeing that you're only sending me a picture of the screenshot and you haven't sent it to PDF and sent it, I'll send you the information, directions, how to do it. And remember, each of these have exactly what is due, what subjects. So when you pull up the NCLEX to do them, it'll tell you due. I think the first one has to do with infants and toddlers and, you know, in pediatrics. Make sure you don't send me med-surg stuff for pediatrics because I go and I check them to make sure that you are doing the proper NCLEX questions, because I'm telling you, some of the questions on the NCLEX, I've seen them coming through with the HESI. So if you've seen it before, it will spark an answer for you. So again, this is just showing you how to do it. And of course, I have instructions. Make sure that you get the best grade you possibly can. You know, NCLEX questions are worth 5% of your total grade. So if you were at that borderline B to A or A from B to C, you know, you do well in this objective, you can pull your grade up quite a bit. Case studies, practice exams, they're going to be open for you as the time comes up, and then I have them open 1 week later. Again, if you're late, that extra week, it costs you 10%, but each one of these case studies is worth 1%. So if you look at this with the practice exams and assignment exams, it is 6% of your grade. So make sure you do the best you can. Go through the modules or I can't accept them, okay? Must go through the modules. Papers must be done with APA, and the only paper you have is the paper on the pediatric assessment. If you don't know APA, you want help with it, you can, there's many sites on the internet, or ask me, I can help you, just set it up easier, or send me your paper and say, can you help me with this? You know, we can Zoom together and I can show you. It takes, seconds. Once you have it written up, out with a reference attached, I can show you. I know many of you want to go forward for your BSN, MSN. So they're going to be, when we get through with the associate degree, everything becomes papers. So BSN, MSN is all papers, papers, and they're going to be looking at APA. So this is your introduction to APA, and I'm going to try to make it as painless as possible. Always make sure you follow your grading rubrics. They're on there for everything. As I said, Purdue OWL is a great thing to insert information. It'll come up with the references. You can have it, and remember, you also have your LRC people that can help you with it. Exams, quizzes, just make sure you follow it through here. As you know, all quizzes are 15 minutes, 10 questions. They're all worth 1%. Each quiz is 1%. Again, any problems, let me know. And what that does is when you send me an email, in fact, I prefer instead of it, well, you can do both, but make sure you put it in Canvas, send me a message there, and then you can text me. It does a timestamp, shows me, okay, I had a problem with that quiz, ooh, timestamp with a message in Canvas, and then I can show what's going on, because my dean is going to ask me, why did you open that again? And I can show you, look, here's the timestamps, this is what went on. Kaplan. Kaplan is not due to the end of semester, but it is ready for you right now. There is no time on it. I do not need a copy of this. You do not have to send me a picture of this. I go in and check every single Kaplan of every single student, and I have almost 100 students. every single thing to make sure you've done Kaplan. Now, what's the big thing with Kaplan? Number one, you go through the Kaplan website here, and you do the different ones. You have math, advanced pediatric math, and you have pediatrics A, B, and C. And you will see that you could do them all. Now, if you do not remediate and you got 100 on that Kaplan, no remediation, you only get a 50. Remediation is half of your grade. If you only do those questions that were wrong, you only get 75% of your grade. So in Kaplan, make sure you remediate. And I only want 1 or 2 minutes per question, even the correct questions, because did you guess that question? Did you really know that answer? It's a reinforcement. It seems like, but I'm telling you, it does help you remember and reinforces that information. And that's what all that stuff says.
Excuse me, Professor.
Yes.
You say for Kaplan we don't have time, so we can start doing them now, right?
There's ABC and math. You can do them right
Oh.
now.
I think I probably already did some of them by mistake.
No, that's fine. If there's no time frame and you do not have to, as long as it's done on this semester, I can accept them. Okay.
Okay.
Because I can see dates and times and everything. I will
Okay.
not score them till they're due, which is week 10
Yes.
and 9, 10 or 10, 11.
Yes, but we can start doing them now. Okay.
And you can see your remediation time there. 30 questions, 29, I'll accept that.
Okay. Thank
And then
you.
our HESI, oh, you're welcome. Not a problem. Thanks for the questions. I appreciate them. HESI exams, it'll be done according to your campus, or if you're not doing them on campus, they'll be done via ProctorU. The schedule for that will be week 11, and you will get that, probably like week 9, knowing when they get everything settled up for that. As I get information, I will let you know about that. With the HESI, once you get your grade, it behooves you to get a 900 or more, okay? 900 or more, you're not going to be doing 28 hours of remediation. I know that this past HESI, with all of the input and all of the work I've done to make sure my Kahoots are covering those concepts in the HESI, I know the grades have come up a lot. So I know my work is working because I work hard to help you. And as long as you're doing your work by going in and doing those Kahoots and doing your reading and, doing your interactive PowerPoints, I know you guys will do really well on this essay. I've had students get 99.99s on this one. So this is that course that you can, if you do what I tell you to do. Make sure your Kahoots are done. You've done those interactive PowerPoints, and you will go back, study for the exams by, going through the PowerPoints, going through the Kahoots, and there's reviews for every single exam here. There are 3 different professors that teach pediatrics. We have Professor Morse, Professor Okorafor, and me. And we all do a review. You will get the recordings for everybody's review, okay? You will have that. On the HESI, I don't do the other review, the PowerPoint review. I actually do a Kahoot review. And that Kahoot, again, I'm teaching you again. I'm reviewing concepts again. And I'm telling you, I spend a lot of time finding questions or making questions up that reflect the concepts that you will see. So that is that right there. Any questions there so far? What's going on? Okay. Let's go and do our other PowerPoint. We're doing really good on time. So remember, if any of these things you don't understand, please, please stop me. I can explain it to you. I don't get bothered. It doesn't unnerve me. Just stop me. Can everybody see that?
Yes.
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 Okay, thank you so much. So here we go. Let's start pediatric nursing, give you an introduction into it. And throughout this course, let's play with some children. And I'm going to show you how to play and how to get children to do things that even the parents can't get them to do. They'll do for you when you're sitting there and playing with them. So healthcare for children, we used to just treat disease and illnesses. Today, a lot of preventative type of medicine is what we're doing in all areas of nursing and medicine. But our goal in Healthy People 2020 is growth and development, getting them to grow the way they should. And the most important aspect of children is nutrition, 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 most important. And then oral health is the other one. Some of the problems we're seeing is obesity, type 2 diabetes. I mean, children are more sedentary. They're playing more games. They're inside. They're not outside as much. Is it due to their neighborhood they live in? Are they afraid to go outside? Or, those things where they're not as active. Childhood injuries, kids get into everything, violence, bullying, and children do have mental health issues. And we'll go into some of them. Guns, swimming, those plastic bags. We know that children pull things off the stove and burn themselves, and they want to get into grandma's or somebody's medicine. I think the biggest thing that children like to, medicine like to get into is their vitamins because they taste good. And today we don't have vitamins with iron. Vitamins with iron are actually dangerous, but regular chewies, those gummy Flintstones, they're okay. They'll just have a lot of vitamins in their system, but they, with fluid, you can get rid of them. Some other health problems, the highest risk children that you will see is those premature infants. Very low birth weight and low birth weight children. When you're born small, you're going to have more problems as you get older. There's a lot of issues that happen with that. We're going to go into that. Children in daycare, what do children in daycare do? And I call it, they swap their spit, right? They go from one toy to another toy, in the mouth, and all they do is kiss and hug on each other. And what they do, and they're just swapping their germs all over. More people are living in poverty and homeless than ever. It takes a lot. It takes two parents or, a lot of creativity today to run a household because it's so expensive. So there's more poverty and homelessness. We have immigrant families. We have chronic medical and psychiatric illnesses. Can you imagine being the child who has CP or a child who has a disease that requires, intensive care, tracheostomies, gastrostomy tubes? We are saving more children that have been premature as they get older than we ever have before because our care's gotten better. And then we have a lot of barriers to healthcare, whether it's health, dentist, psychiatric, and it's sometimes due to they don't have insurance because they don't have money. Or a lot of them are the immigrants and they're afraid to go and apply for insurances because they don't want to be deported. All of these things play into this. Infant mortality, you'd think that the United States would have one of the lowest infant mortalities in the world. The answer is no, we're one of the higher. When you have those big countries, you have like Sweden, it's probably the lowest infant mortality. But infant mortality is a number of deaths per 1,000 live births during the first year of life. So we have a neonatal, which is very early, in postnatal, which is later after the month. And birth weight is the big thing. I've seen children born at 1 pound. 425 grams was the smallest one I saw. And they could literally put you in your little hand. Their heads are, the size of a $50. They're very small. I've worked a lot of newborn intensive care unit. Childhood mortality is death rates for children are greater one that are less than the infant. So when you're born, you have a lot more chance to becoming ill. After you get to age 1, your body's built up immune systems, you know, and you're stronger and it decreases. As we get older, there's different things that causes childhood mortality. I think injuries, you know, all sorts of injuries. Think about the toddler, ages 1 to 3. I call them the dive bomb kids. They get on top of things, they jump head first onto the floor, into the couch. They're trying to climb up things to turn the TV on or to grab a cookie. Injuries are the big thing. Homicide as they get older, you know, accidents, and then suicide. That's more of your teenage area. So chapter 27, going on to family, social, cultural, and religious influences. Now, children are what their family is. Think about that. Children are what their family unit is, what they believe in. That is what a child becomes. Now, when you talk about pediatrics, we are not just dealing with a child. That's not our patient. Our patient is the family. The family is that one constant in a child's life. And when we're talking about taking care of a child, especially a special needs child, we need all the family members involved. Let's say you had a child who had to be on a restrictive diet, like in diabetes or nephrotic syndrome or something, you know, and they can't have salt or sugar. We need to tell those brothers and sisters why, so that they're not trying to tease their brother or sister, you know, that they can help them get better. And the family is whatever they say the family is. Now, families could be moms and dads, be 2 moms, 2 dads, could be the mom and a grandma. It could be, you know, a friend and your mom. It could be, you know, all different children from different places. Whoever it is, the family is whatever they say the family is, okay? There's a lot of different ones. It's not just mom, dad, and child today. There's many more. And remember, each member influences that child on their values and their culture. The thing we're doing today more and more is providing atraumatic care. You know, as I was talking earlier about my dissertation and school-age children and fear of injections, we have started a lot of stuff to prevent that painful experience. We're doing numbing creams, et cetera, et cetera. So today, you know, we do more of a therapeutic care. We make sure that we're looking at that child holistically, that we don't want to just go in and say, oh, here's a blood pressure, let's put it on, let's do it. You know, we're doing different things, different interventions to help them. We're working with distractions and letting children touch and feel and play with the information. And what this does, it decreases the stress of that child. It shows the child being part of the care, not just sit there, let me get something done. Children, you can't go in and just do something. You must spend time with them first to be able to get it done in a proper way. We want to minimize any physical distress at all. And of course, we want to do no harm, of course. And as I said, there's all different sort of families, you know, and we could go on and on about the amount of them. Cultural beliefs are very important when we deal with children. When we're looking at children, for instance, I'm going to give you some great examples. I live in South Florida. I live in Homestead. I'm on the gateway to the Keys. I'm 30 minutes, I'm in Key Largo. I'm very south. A lot of the population here are Hispanic. When you have an Hispanic child, you know, and the family comes with you, and they're coming in with a fever, many times this infant will be wrapped up in a blanket with a hat on, 3 different layers of clothing because they have a fever. Because they feel that you have a fever, they're cold. And they're shaking, right? Because they've got a fever. It's just part of it. So explaining to them how the fever stays in that clothing, they need to take it off so the fever goes away. Another thing about a fever, especially with the grandmother of a Spanish, they need to be able to walk around on the floors without socks on. They will not have their children walking around on the floor without socks. But if you have a fever, walking on a cold floor does what? It decreases the fever. So this is that hot, that cold, that clothes, no clothes, things that you might see are part of it. Another thing is, what are things, that we have to worry about with cultural beliefs? Well, if we have a child who has to pray 6 times a day, we need to work our care around them, not them around us. We need to be respectful of that. If we're having families that, especially from the Middle East, where the father is usually the center, and you can't stare at them, you can't touch them, you have to respect and understand what those cultures are all about. Another thing, let's say you're Jehovah's Witness and you need to give that child some blood. Now we know that Jehovah's Witnesses don't believe in that. So administering blood and being respectful is what we need to do, because we'll get a court order to do it, especially if a child is symptomatic with it. So cultural is so, so important. So I've talked to, and then of course, going outside and the kid got sick because he was outside in the rain, or he went outside and didn't blow dry his hair. All of those things are part of some cultural beliefs, and it's okay that they believe in that, but you need to understand it to be able to teach these parents, even grandparents, because down here, grandma, grandpa is very important, even aunts and uncles and best friends, and in many cultures. As I said, those religious beliefs and practices, blood products and giving them. What about if you're working with a culture that doesn't, is only vegetarian, and then you serve somebody sausage for breakfast? That's totally against their beliefs. So making sure we understand. Now, do we have to know? No, we don't have to know everything, but we need to ask the parents, what sort of diet do you want your child on? What sort of juices, what sort of things don't you want them to have? If you ask, this family will be so more happy with you because you have respected their culture, respected what they believe in. Many cultures, like Jamaicans, my husband's Jamaican, he believes in natural remedies and medicines, like different teas. These sort of things can interfere with other medicines. So we have to make sure that we know, okay, does your child drink any tea? And the doc and the child and the parents. It is a big responsibility to be a pediatric nurse. And many nurses don't go into pediatrics because they don't want to deal with the families. They don't want to deal with mom and dad. And I understand that. They can be very difficult. I was the nurse that they would always give the difficult parent to, because somehow, some way, I could work with them and I could make them understand what we had to do and why we did. You're almost like a counselor at this point as a pediatric nurse. I mean, in any nursing, yes, but especially in pediatric nursing. So building up that good relationship and, having and teaching everything we can. I've had children that I worked with in the cardiac intensive care unit. Those children tend to stay there a little bit longer, some of those conditions. And 18, 20 years later, I am still getting messages from those parents. On Nurses Week on Facebook, I will get messages from several parents, to Chris's favorite nurse, and all it was is because I spent time with the child and I spent time with the parent and I did good teaching. I had children who wouldn't go to surgery unless I was there to take care of them post-operatively. It's just a bond that you build. In pediatrics, you get to do that. And it's something I've loved. I've been a parent to I don't know how many kids out there that are still there, but I still get the rewards from it. As I said, you're the counselor. Many times, you have a child that you have to do some ethical decisions making, like, is this child, we think that all children should live. There are sometimes with conditions that sometimes the hardest choice is to let the child die in peace. And you will be a part of that. It is hard. And it's something that I've cried many times from, with parents, without parents, don't matter. I'm a human and I'm allowed to do that. So I have. We know that pediatric nursing, we do all of our practices on evidence-based practice. If I can tell you how many changes have occurred in medicine, in nursing, since I started in 1976 to now, your mind would be blown. And I've had to keep up with that as we went on. One example, we didn't have an IV pump when I started nursing. We only had that little roller clamp, and we had to we had to monitor IV fluids dripping in. I knew that if every 3 seconds a drop would drip in the chamber, that IV was running at 125 mLs an hour. And I would count drops. Every 4 seconds, it's 75 mLs an hour. Every 2 seconds was 150 an hour. And these physicians wanted their IVs on time, and I didn't have an IV pump. So that's one thing. And of course, now there's pumps on everything. Chapter 28, going into nursing care. Always remember ADPI, okay? We really, when you are going and looking at questions, especially on exams and quizzes, look at it from the perspective of ADPI, the assessment, what you think the diagnosis could be. What are you going to plan to do? You're going to implement it and evaluate it. These are ways to look at questions, whether med-surg 2, whether pediatrics. You need to tear the question apart. These symptoms were given in a question. What do you think it could be? Okay. And then look at what the answers are. This one makes sense. So the leading cause of death among African-American boys ages 15 to 19 is what? What would you think? Firearms. And then you'll see those answers will be in the bottom, in your note pages, just to let you know, okay? So growth and development, there is a sequence of growth and development. I think next week, as we go into the infant, we're going to see an infant born at 7 pounds, becomes 21 pounds, has grown inches, only could suck on a bottle, and now is up and walking all over the place. It's incredible what an infant does in the first year of life. It's all interrelated, simultaneous, and ongoing. Now, as you do your readings, you're going to see directional, sequential, and developmental pace. This is the way that children grow. There is a certain pathway. That's why your doctor will look at your child, and let's say they're 8 months old, to see, can they sit up unsupported by themselves? Okay. It doesn't mean everything has to be done on time. Doesn't mean they do everything. Sometimes you pass steps. So let's give, an example of a gross motor. Gross motor has to do with walking in the end. And it starts out with lifting the head. That's the first thing. Then they turn over. Then they get on their knees. Then they get up and they creep, and then they walk. Doesn't mean that they're not going to go from turning over to be able to sit up. Some children go quick, some go slow. It doesn't mean that there is a delay at all, as long as they're progressing forward. Some children walk at 9 months. My children didn't walk till they were 15 months, and they didn't walk, they ran. And it's just a difference as long as they're moving forward. So these are some terms that you will see. We know as they are small, they tend to burn up a lot of calories just by sucking, swallowing, and breathing. That is all they do as an infant. We know that their temperature regulation, when they're born, they don't have any. So we need to make sure we keep an infant warm. Why would we want to know that? Well, you have a newborn baby born and you need to do an assessment on them. You need to make sure that they're either in a heated, warmer isolette or that they're covered with a blanket, because they will drop their body temperatures really quickly. We know infants sleep a lot. They, eat, they cool a little bit, and they sleep. They sleep about 20 hours a day if we're lucky, especially if they're doing that during the nighttime. And again, nutrition is the single most important influence on growth. If I'm telling you they grow from 7 pounds to 21 pounds in the first year of life, they need a lot of nutrition. And remember, they're growing their brains, okay? This is part of the synapsing going on. Not proper nutrition, their cognition is going to be delayed. So nutrition, nutrition, nutrition. And we're going to see what sort of child they are, their temperament, and they're going to know people around them as they get going. Now, I'm going to be sending you a handout on Freud, Erikson, Piaget, Kohlberg. These are very important. You're going to see them on quizzes, hint. You're going to see these on exams, hint. And you're going to see them on your HESI. So very important that you get very familiar with the different stages of Erikson, understanding Piaget, and Freud and Kohlberg. Fowler, I've never seen, just to let you know. Now, as I said, with children, I play. Now, in children, playing is the most important thing that they do. What it does, it gives them that sensoromotor development. What does that mean? Well, you touch. It's the texture. Everything in the mouth, everything in the mouth, and then moving it around. It's looking at things and learning. It's part of their cognition growth. Toys are important. And then they know how to take, eventually put if it's a little boy, put the car on its wheels instead of on its side. It also, when you put, a toy with a baby and you're with them, it's a part of that socialization, creativity, and then it starts like this little baby here with stuff everywhere. It makes them aware if they have hands. Okay, now they're learning they have hands and they have mouths. So toys are very important. Now, playing. There are different classifications of playing, and it's something that we do talk about. It's playing alone, playing with others, and playing with a goal at the end of it. So in your readings, go over this and see it. Onlooker, somebody's doing something over there, and I might, do the same thing. Solitary, I could be at the beach filling up my pail full of sand by myself, or I could be with my brother that we're doing the same thing, but alone. Sometimes we're sharing together, and then cooperative play. So types of play, you will see this again. Toys, again, it does support children's development. I like these maracas and this kid. I have a grandson who turned 5 yesterday, and you'll hear me talk about Christian all the time. I was very blessed to be able to have him in my home for the first 3 years of his life. My daughter lived with me initially. So I got to watch this kid grow and had so much fun playing with him. And one thing we used to do with toys is we would shake maracas and we would bang tamarines and bells and we would sing together. It would be singing, I love Christian and Christian loves me. And we would be banging things and he would giggle and coo even as an infant. And then still today, he still sings the same thing with me. It does help that good bonding between parents or grandparents with their child. And it does show them how to use things, that things have usages. Now, as a nurse, you will have, if you ever work in a doctor's office or, working, in the hospital, you're going to have to do an assessment of them and see if they are developmentally where they need to be. So we know when a child goes to the hospital or ER, urgent care, to the office, they're going to have their height and their weight. We always look at that. That's two things for sure. That's a given. But then we're going to be looking at what they're able to do. Can they follow directions? You're going to see a lot about grasping. We start out with involuntary and voluntary, palmar grasp and pincer grasps. Can they do these things? Now, if we're finding, let's say, a child, now you should be able to roll over front to back and back to front by 6 months old. Should be done. If this child is 8 months old and can't roll, guess what? We've identified a delay. And what do we need to do is find out why. Maybe we need to institute some sort of therapy, speech therapy, occupational therapy, physical therapy, but we can catch this child up. Or maybe it's something medical going on. Maybe it's a brain tumor. Something's not right. We need to look and we need to catch that child up. So these developmental assessments, or these assessments that we do, and looking at the child where they are so important, because we can find delays. And if we're finding delays, we can act on them and we can get them the treatment they need quickly. Children are born with all sorts of congenital abnormalities. I mean, the heart is a big one. We'll get to that. But they can be born with clubfoot. We can be born that they're missing, part of the arm or the leg or a finger, or, an extra fingers, cleft lip, cleft palate. Those things are all things that we can have congenital abnormalities. And then we can have all sorts of syndromes that can be occurred. Downs, we can test for that now. Prader-Willi, Turner, these are all syndromes, and they all have their own type of outcomes, and we can determine, what is normal for them according to what these syndromes are. And these are genetic, and it also will help those parents also check themselves for their genes before they decide to have another child. We know things like chemicals, rubella, we've heard German measles, radiation, and then of course metabolic can cause problems with growth and development. And it's things that we need to be looking out for. We know that there are many disorders, 22 pairs of chromosomes. I mean, Q22 deletion is a DiGeorge syndrome. So knowing these things, and then we know what these children should be able to do. So if we know a child has Down syndrome, or if we know a child has DiGeorge syndrome, we know that there's certain things that these children need. And then we can incorporate that into the care. And we can also teach our parents, what do we need to do to help that child be the best that they can possibly be? The one thing you'll hear me say all the time is early intervention. The earlier we can give intervention to these children, the better outcomes there will be. I was working and I did clinical rotations for Fortis College, and I worked at this PPAC, which is a prescribed pediatric daycare. These children have to have a condition that require it. Now, talking about early intervention and how it can make a difference, well, if anybody knows children that are autistic, severely autistic, and have Down syndrome on top of it, you can imagine they could possibly be a very difficult child to work with. Well, there's a child, this little boy, he's autistic and Downs, and he's been going to this prescribed pediatric daycare since he was a baby, an infant. This child, number one, his tongue doesn't come out of his mouth like most Downs. You usually see a tongue. You don't see that. You will see him walk in, go around, sit in a chair after he puts his backpack in a cubby. This is an autistic Downs child, and he will wait for them to do the vital signs before he can go off and play. Now, that doesn't happen with normal children autistically Downs, but because of early intervention, he knew what was expected of him and keeping him on that same routine. This child also liked to be hugged. Autistic children hate to be hugged. They hate to be touched. And this child would come up and hug his favorite people. So seeing that just absolutely opened my eyes to, yes, early intervention is great. Now, a father tells the nurse that his child is filling up the house with collectibles like seashells, bottle caps, baseball cards, pennies. The nurse should recognize the child is developing what? What do you think?
D.
It's what we call a concrete operational thinking. This has to do with Piaget, okay? And what he says is, when you have things together, it fills a void in that child and they want to see more of it, okay? Object permanence. When you have an infant and you show him a rattle, when it's gone, initially he doesn't know it's gone, okay? But after you've done the rattle shaking a couple times, the infant will go looking for it. And that's object permanence. Even though he can't see it, he knows it's still somewhere. How about that little toddler? You put his truck away and then you turn your back, he goes to the toy box and pulls it back out because he knows even though it's not in his sight, it's still going to be there. And then communication. Well, we know about HIPAA. It doesn't matter if you're an adult or you're a child, we have to be concerned about HIPAA. And now communicating with families. Now, pediatrics has a very different thing. When your child goes to an emergency room or is admitted to a hospital, I mean, it's COVID today, but you usually would see in my environment, the culture here, you see mom and dad, grandma, grandpa, usually aunt, uncle, and your best friend all come in because they're all concerned about the child. Now, who do you talk to? Who knows the most about that child? Well, so who am I going to talk to today? And okay, you're the mother. Now, do you mind if I speak in front of all these people? Very important, because you don't know if you can or you can't. And maybe there's information that mother or father don't want everybody else to know. So very important. Who am I speaking to? And tell me, can I talk openly and honestly? Make sure that we listen while they're talking. And one of the things about parents and their children, sometimes you have a 3-year-old that you're getting information about, and the mother starts with the birth history in detail. You're like, okay, so it was a normal delivery at birth. So nothing really, like premature, et cetera, et cetera. So you say, okay, it was a normal delivery. Can you tell me why you're here this time? Because sometimes they'll go on for an hour of everything that's happened up till 3 years old. And I've seen that happen. So, we want to know what's happening this time. One of the things I have learned, especially if you have a young infant with parents, and let's say it's a child who has a fever. Most of the time, a little infant's had a fever. They've already called the doctor. They've already been seen. They've gone in again. Let's say now they're in the emergency room. One thing I'll say is, you must be exhausted. I said, you've done such a good job. Let's figure out what's going on now. What I have done is I validated that parent, that they've done a great job, that they are tired, and I'm going to do something to help. Any questions, just please ask me. That's that empathetic moment. And when you do that, that parent, you can see them relax, like, okay, she's going to help me. And then if you have a parent that you don't understand the language, you cannot have the teenage brother do your translating. You must do it through an interpreter, whether it's one of those blue phones or if they have an interpreter in the hospital, whatever, because we do not want any of their feelings interpreted in that translation. So whenever we have, you can't speak to them, make sure you do it through the proper chain. Communicating with children is fun. Sometimes it's, first of all, you need to get on the level of the child. Many times, if they're a young child, I'll sit down on the floor, on the bed next to them, and I'll start talking about school or daycare or their brother, or, oh, look at that cool shirt you have on. Oh, you like Spider-Man? Or, oh, that's a pretty bow. Oh, I like your freckles. Oh, blue eyes. Wow, those are gorgeous. So I've now relaxed the child. I'm getting on their level. And now this child's going to talk to me. Sometimes, we can do communication through just pointing. Sometimes it's with little games. Sometimes, it's just giving a hug and they're okay. But when you play with a child, this child's going to open up and tell you a lot more, especially if you started on the level of that child and you started off with making them feel comfortable with you, like you are not a threat. To do a history, as I said, you need to find out who's the informant. Sometimes it's grandma, it's not mom. Sometimes it's the aunt. They were with the aunt all weekend. So, make sure you know who the informant is. What's the chief complaint and what is the present illness? Okay, and what are the symptoms? What has this child been showing you? We do need to know if it was a normal delivery at birth, but we don't need to go into super detail unless it was a premature who was intubated, etc. If they're eating, what do they eat? And if there's any sort of illnesses, past medical history, you always want their allergies, any medications that they're on, because if you need to give Tylenol, Motrin, you need to know if they've had any. Their immunizations, are they up to date? This actually helps you know that is this child, could they have something because they're not immunized? You will see there are children that aren't immunized today, and it's a parent's decision. They say it's their religious choice. It's okay, I'm going to wear a mask and I'm going to do very good care for me because I don't want to get something that they could be carrying. Also, knowing their growth and development, has it been normal, and any habits. I want to know, do they need a blanket to go to bed? Do they have a favorite toy to go to sleep? Especially if I'm admitting them to the hospital. So I can know what to look for that child. Do they like to suck their thumb? Do they like a pacifier? Tell me their habits. Sexual history is mostly going to be talking about your adolescent. You can ask the parents to leave the room. Would you, as an adolescent girl, tell the nurse about sexual habits in front of your parents? I wouldn't. My mother would beat me up, if I told her I was kissing a boy or something, or even more. So a lot of times, to get a good medical history from adolescents, parents will leave the room. And as long as the information cannot harm the child or others, you do not have to tell the parent, okay? Because it's in confidence. It's their right to tell you, but you don't have to tell the parents unless it can hurt them. We need to know, what is that composition of that family? Is the father in charge, a mother in charge, a grandma? And you're going to see all different levels of that. School adjustment, I do very easily. So how you doing in school? What's your favorite subject? What's your teacher's name? Do you like her? Do you have a good friend at school? I mean, all of these things you can see. One of the things about parent-children relationships, I can tell a lot with that by just the way that they are. The last part of my working at a hospital was in the emergency room. I was a trauma nurse at Nicholas Children's Hospital, worked in a very extremely busy emergency room. And you could see the way parents and children would respond to each other. I've had parents that they're sitting on the stretcher next to them and holding them. Then I have parents sitting in the corner on their phones, watching TV. The child is there getting into the otoscope and all the little black ear things, and tongue depressors and stuff are flying all over the place, and the parent has no clue what's going on. So I don't know what sort of relationship that is, right? And then with history, of course, you need all of their systems of the body. And if the child is older, I ask the child, how do they eat? Anything with their culture do I need to know, especially if this child's being admitted, making sure that I'm not going to offend them by giving them any foods that they shouldn't have. And if we have any issues regarding their nutrition, we're going to have the dietitian come up and talk with them. Physical assessment, as I said, height and weight are done on all children. It's just following to see if they're in that growth curve. Where are they in there? In infants, we do chests, we do abdomens. Remember, infants are born with a big head and their chest is smaller than their head. By the time they get to be about 2, their chest should be bigger than their head, or at least equal to it. Actually, I believe that was a HESI question in OB. One of the students had told me about the head being bigger than the chest. And of course, we're going to take their temperature, making sure they're normal. Pulse, respiration, blood pressures. You know, to be able to do that on a child, I let them play with the toys first. Here's a temperature. Do you want to do it yourself? Or do you want me to do it? Or can I tickle your little arm? Or here's a blood pressure. Where do you want me to put it? You put it here. Let me show you how to do it. Will you push the button on the electronic one? Make it a game. And these children, you'll do a blood pressure, which will be, you know, an accurate reading, you know, listening to them, their respirations, their pulse. All of these things are done so much better by having it as a game with these children on their developmental level, letting them touch and feel all this equipment first, you know, having them touch my lymph nodes, you know, look at my, you know, ears. You want to see my ear too. Make it fun and you'll get it all done. We do inspection, auscultation, palpitation, you know, the abdomen. Again, visual is your first. You can see a child in pain. You can see a child in respiratory distress from a distance. If you look, you can see that grimacing. You can see them bent over. You can see retractions. You can see their color. All of these things are so important. And we do assessment even of the genitalia. Well, if you're an infant and you are a male, we're concerned about the testicles to be down, distended testicles. If we are a female, sometimes you have fused labias. I've seen them almost completely fused shut. And no, we don't cut it open. We just put a little bit of hormone cream on it and it opens up by itself. First time I saw that, I was like, oh, okay. We're going to look at the anus, the imperforated anus. You know, as a baby is born, one of the first things we do is a rectal temperature. And you're taught you do the rectal temperature because you want to make sure you have an accurate temperature, but you're also making sure there's an anus there. There are children born without it, okay? And that is a surgical emergency because you have all those secretions and there's nowhere it's coming out. So that child will have a colostomy pretty quick. We're going to be looking at their back, making sure it's all formed because there's things that happen where the spinal cord's born on the outside. We're going to take their legs up and down, making sure their hips, that they're in the right place. We're going to be checking all of their nerves. We're going to check, you know, startle reflex. We're going to be checking so many things on this little tiny infant. Head, chest, abdomen. That's on infants all the time. On older children, we don't really do head or abdomen unless there's been a problem. If they've had a colostomy or they have GI issues, we'll be doing abdominal circumference. But if not, we don't. Head circumference, let's say they have hydrocephalus, we'll be doing that. And then getting their height. Now, you think getting a child to stand underneath that bar is easy? It isn't. I worked in the triage area in the ER quite a bit. And we had one that looked just like that you'd have to put that little thing there. So let's make it a game. So I'm going to take my height first. Let me see what my number is. And I put the thing there. I said, don't worry. It's not going to hurt you. It's not going to bop you. Oh, what number do I have? Oh, I have a 7. Let's see what you are. All right, you turn around. Here, let me hold it. Okay, can you feel it touching your head? Oh, look, your number's a 6 or your number's an 8. Oh, you're bigger than me. Now I've gotten a height. The child's not scared and the child's still smiling because you do not want to create issues because maybe that kid needs lab works, an IV, needs an x-ray. You don't want to start the problems that quick. So make it a game. Let's have some fun. There are blood pressure cuffs from size 00 to adult extra large. You need to choose the proper cuff for the child. So as you're doing a blood pressure, what number cuff is what you need? You can do blood pressures anywhere. I have found with children 2 and 3, the one on the lower leg is the best one because I can hold that leg and they're fine. The upper arm, they don't like it. It tends to squeeze them and it hurts them. You can get just a good blood pressure on the lower leg as you can on the upper arm. The only time where we would want to do it on the upper arm and the lower leg is if it's cardiac. We want to measure upper and lower blood pressures. There's reasons for that. Again, physical assessment, look at them. What do they look like? We're going to listen to their chest, their lungs, their abdomen. We're going to see if everything's there. We're going to check reflexes. I love to give those kids those hammers and let them bop their own reflexes and watch their legs go. And they just think it's so much fun. Come on, mom, sit down. You do it too. And they do it on me also. And then pain, our last chapter for today. Infants have pain. How do they tell you? You think that infant there is in pain? Or do you think that infant's hungry? It could be either, couldn't it? So one of the problems with pain management is probably my biggest pet peeve in nursing is that we don't think children suffer from pain as much as adults. Children will not tell you they're in pain because they don't want a shot. So they think that, or they don't want the medicine. So they say, no, I'm not in pain. And they're there, you know, they're grimacing. You can see the little lip is quivering. You know they're in pain, but they will not tell you they're in pain. So sometimes you have to look at the child and say, we're going to give you something. One of the things nurses do, they give lower than recommended doses, or they wait too long in between them. Now in pediatrics, we give milligrams or micrograms per kilogram. It is not just, you know, 2 Tylenol. No, we don't do that in infants. We give milligrams per kilogram. And again, we look for the pain, we give an intervention, and we need to go back to make sure, did it work? Or do they need something else? And the other thing with pain that we forget, it's not just giving a medicine, it's making sure what comfort measures did I do? Did I get that child straightened up in bed? Did I elevate the head of the bed because their tummy hurt? Did I put the TV on cartoons for them? Did I give them their favorite blankie or toy so they can hug? It's all those things, hot and cold packs, all of those things work just as well as the medicines. There's different pains, chronic, recurrent, persistent. You know, chronic pain could be rheumatoid arthritis, could be sickle cell reoccurrent. It could be we're in a bowel obstruction, you know, and you're not going to take care of it until we do surgery. Pain could be caused by many things. I think probably in children, the biggest pain is an earache. And what they'll say is, I'll say, what ear hurts? And they don't put their hand on this side. They always go to the other side. And they go, no, it's this ear over here. And I always chuckle with it. So to make sure that we do give medicine for pain and that we treat it accurately. It could be due to surgery. It could be due to putting on a cast. It could be due to they fell down, they broke an arm. It could be an ear infection, or it could be like sickle cell. Now, there are different pain scales that we do use. On the bottom here, this is Wong Baker pain scale. It's the smiley faces one. This cannot be used until they're 3 years old. Preschoolers can use this. So ages 0 to 2, you cannot use it. There's something else that we use for them. These children can literally look at that and say, how much pain are you in? And they'll point to the face and they'll say this much. And when they go up and they say very severe, it makes me, poor little thing, let's get you something. So making sure that we document with the proper pain scale. Now, you'll see in the book, there's many different pain scales. The ones that you're going to see is FLAC, and you'll see faces, and you'll see numeric. Now, cries is basically to do with gestational ages, but the one that I like to do is The faces, as I said, those are your preschooler and older. Numeric, from scale of 0 to 10. 0 is no pain, 10 is the worst pain in the world. How much do you hurt? That's usually for children ages 8 years and older. It doesn't mean a 5-year-old couldn't answer it, but according to the book, it's 8 years and older, okay? And then the bottom one here, a nonverbal child. It could be an infant, or it could be a 16-year-old CP child who's nonverbal. Doesn't matter the age of the child. It just means nonverbal. And what they do is FLAC, and it looks at the facial experiences, looks at the legs. Are they moving up and down and shaking? Their activity, their cry, and their consolability. Are you able to pick this child up, hold them, rock them, and they relax and stop crying, or are they still crying? So, and there's different numbers we give according to each one of those levels, which come up to 10. So chronic pain is pain that lasts 3 months or longer. It could be something, your sickle cells. It could be rheumatoid. It could be many different things that children can have. Can you imagine being in pain all the time and how this child would feel? Chronic pain does really affect every part of your life. It affects physical, emotional, social, and school functioning. If you're in pain, you don't want to do anything, so addressing the pain is so important. Remember, in pain, besides children not wanting to tell you they're in pain because they don't want medicine, remember there's cultural differences. Think about some cultures, and I'm going to go right to the Hispanic again. The father's telling the little boy, you're not in pain. Tough it up. You don't hurt. You're okay, right? You've heard that before. And of course, the kid's going to say, yeah, no, I'm not in pain. I'm not in pain. No, I don't hurt. I don't hurt. And you know that they are. Remember those cultural things. And then remember that our children that have complex illnesses, and as we go on, we're going to see all different sorts of things. And some of these pains, it's complex. And, we are today addressing pain better than ever. And as I said, besides just pain and medicines, we need to be able to do something else. I think distraction, I think giving them an iPad, some of these kids let them play, or give them stickers or a game, or put on TV, or, play peekaboo, do something. I'm telling you, it distracts them from their pain, and it could be any of these things. Non-nutritive sucking, pacifier. Today, we use a little bit of sugar water on a pacifier on an infant, and it's like giving them morphine. It's self-soothing, and it eliminates pain. There was a study by Harvard neurophysiologists or something, these crazy people. They did it on pacifiers and children and pain responses, and they found it acted just like morphine. So a pacifier, little sugar water on it, and it will take care of pain. And it's common practice today on infants, starting an IV, giving blood, doing, catheterization, anything, we will give them the pacifier, and they do calm down. And of course, this is kangaroo care, where, the little premature baby is up on mom on their chest. I have seen kids that have heart rates high, nobody's consoling them. You put them on mom's chest, and you can watch the vital signs, the heart rate come down, the blood pressure come down, and you could see they're just so relaxed. We could give old morphine, or we could give something as simple as Tylenol. Works just perfect with infants. Now, for the first 6 months of life, the pain medicine that we can give is Tylenol. We can give morphine for sure, but out of the over-the-counter, only Tylenol for the first 6 months of life. At 6 months, you can add in the NSAIDs or the ibuprofen, Motrin. Opioids are given. Sometimes in between, we can give Tylenol or Motrin, and it could help. And there's all different sort of ways. And as I said, hot packs, cold packs, positionings, all of those things work really, really well. Now, this sure, go.
It's from two slide before. What is kangaroo care?
is when you take the baby and put it on her skin. That's kangaroo care. Like a
Okay.
kangaroo, the little billy
Yeah,
or
'cause they
whatever it is
carry it in a little
inside the
pocket.
pouch.
Yes.
Yeah, well, that's the
Okay.
same thing. They put them
Okay.
there. And
Okay.
even really intubated kids, we put them on mom, and we have found such great
Yeah, I like it.
results. It is
Yeah, like the
perfect.
skin to skin. Yes.
Oh, skin to skin. Yes.
Okay.
Thank you. You see this little girl? She has that little patch on her arm and she's smiling. She's just about to get her blood drawn, but that's EMLA cream. It's a numbing cream. So she knows that, yeah, she's getting her blood drawn, but she's not going to feel it. She's going to feel touch, but she's not going to feel the pinch. So she's happy. So that's a change in children. You used to say, yeah, we're going to draw your blood. They'd be running down the hall in the opposite direction because I don't want my blood drawn. But you can see that this really, really helps. So thinking about ways to decrease pain before we need to inflict it really help. We know teething, vaccinations, circumcisions. My grandson at 1 month old had it done with a pacifier with sugar water and did very well. And, you know, circumcisions, it's cutting the skin off. So that's quite a big procedure. Remember, in post-op pain, it's not just the medicines, it's positioning. You had an appendectomy, abdominal surgery, and they're laying flat. If you lift them up, give them a pillow, you know, to splint their wound, oh my God, with the pain medicine, it's going to help so much better. So make sure you use a variety of stuff to help them. Headaches, pain, pain, pain. And then the one pain thing is end of life. You know, if we get a child, you know, who, you know, we know that there's no more we can do. And probably the hardest place to work in nursing, a lot of times it's on the cancer floors. We've done everything we can. And, you know, now we know that we just need to keep this child comfortable. We do combinations of care, of medicines. We give things like Versed with morphine or whatever they need to have them comfortable at the end. You know, and it's very hard to work with that. And as I've told nurses, you know, I wish we could save all children. We just can't. But it's okay for you to cry too. And I've cried with many parents. We just sit there and hug each other because, you know, I am a person too. And actually, it does help them feel a little bit better that, yeah, she does care. She cried with me. All right, we got a Kahoots. Let's do it quick, get her done, and we'll be done for today.
For Cahoots, am I supposed to download this app or something?
Kahoot.it.
Cahoots dot.
It's an app you can get on your phone too.
You,
Oh, app I
you're
have,
gonna,
to, put my,
yeah,
I have
yeah,
to get it
yeah.
on my phone.
On your
I
phone.
said you
yes.
can.
Oh,
Well, you have to because you're on the computer. So you have to put it on your phone. Kahoot.it.
so I gotta set up a password and all that, I guess.
Go ahead, take your time.
Okay.
Now I'm going to send you the links to this also, okay? So you can have these to review. So when I send you your recordings, you're going to see the recording for the lecture and you're going to see the link, how to go back and look at the Kahoots. I've had students who like to write out the Kahoots, you know, to be able to understand it better. And as they go back, they'll look up the reading to see, you know, what more do you need to understand about it. So www.kahoot.it.
Oh, wait a minute. What's this?
Now, this is your PIN number.
Okay.
You might be able to go to that Q reader and go through there. That's new.
Go. Oh, wait a minute. Okay.
Did you find it, LaShawn?
Yeah, I'm waiting for it to
Okay.
install.
Cool.
Question, is it okay if I follow along for today because I'm in the line waiting for my kids, picking up them from school?
That's
sorry.
not a problem. It's not a
Okay.
problem.
I'm sorry.
No, I understand that. And I like the honesty. No, not a problem.
Thank you.
Yeah, it's taking forever. Hold on.
I know that you have a life beyond school. I get it.
Actually, I just set up the bus today because I never have class like this because my husband just start working back, just go back because he's a soldier. So I'm
Where is
like,
he?
oh my God. We're in Fort Campbell. We're in Tennessee.
Okay. My son is Special Forces, Army.
My husband is Army, yes.
Yep, Army air.
But my life, I spent my whole life in Florida. When you say you're down south, I know where you are.
Yep. Have you ever been to Homestead?
Yes, I've been in Homestead a couple of times, yes.
Okay, that's where I live. I'm right down the street. I'm about a quarter mile as the
Yeah, my
road
mother
flies.
live in my mom live in Miami, but she used to work in Coconut Grove. So I used to be in those areas a lot.
I live in Waterstone.
Okay.
You know exactly where I'm at. I'm
Yes.
on the Campbell side, closer to the hospital.
Yes.
Look at that. Uh-oh, you know where I live.
Mhm. I'm a Miami baby.
Shouldn't are you able to get it? It's okay. We're going to start. It's all right. Just listen along, okay? Because it's getting late. I don't want to go over, hardly at all, okay? I'm usually done before 5. Usually. From a worldwide
Something we can always get
perspective,
into.
infant mortality in the United States. Infant mortality, what did I tell you about that? Are we good? Aren't we? You're going to be able to pull these up and go through them with the link I send you with the recording. So you'll be able to review these again. So infant mortality is the highest of the developed nations, which basically is telling you that, United States could do a lot better than what it's doing right now. And Carly's up top. Let's see who's going to win today. The leading cause of death from unintentional injuries in children is. Now, I'm giving you a lot of information. You're going to see a lot of different stuff on infants, etc. But these are things in your readings for next week that you're going to see, okay? It's giving you that introduction to concepts and things to be looking for as you do your readings. Now, unintentional injuries, the biggest cause of death is motor vehicle fatalities. And it's not just in the motor vehicle in an inappropriate car seat or whatever, it's being run over. I can't tell you how many children I saw that they were backing up the aunt, the uncle, the neighbor, the mother, the father, and ran over their child. And that's why today that they have those backup cameras now, because of the amount of children that were ran over, to tell you the truth. I've seen children get not a scratch, and I've seen children get quite bad injuries. Which statement is most descriptive of pediatric family-centered care? Well, we know the family is whatever they tell you their family is.
Mm-hmm.
And we know that the family is their culture, it's their beliefs, it's the way that they are, but it is that one constant. Family is that constant, especially when they're younger. After they get to school, there's a little bit more influence, but the younger children, it's their big constant. And Kristen is on fire. She's getting them all right. The major cause of death for children older than 1 year is dive bomb kids, as I call them. I think toddler is my favorite age of children.
No injury.
I hear a baby. The major cause of death is unintentional injuries. And it doesn't, which means we didn't try to do it. These are these children that are running out in front of cars, that are jumping off of couches. These are children that, get injured. Nobody's fault. It just happens because that's children. It's what they do. They fall out the house and they break their ankles. I mean, all of these things, unintentional. What statement best describes the process of critical thinking? What is critical thinking? Isn't it ADPI? I think critical thinking is, I need to make spaghetti tonight and I don't have the ingredients and I need to go to the store. So I make a list and I get all the ingredients at the store and come home and make it. It is purposeful and it's goal directed. Do you see how that just happened? I made my spaghetti because I made my list. I went to the store, brought it home, and I made it. Purposeful and goal directed. And Kristen is now on top. What is probably the single most important influence on growth at all stages of development? What's the most important thing with children? I mean, all they do is grow. Grow, 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 grow. What do you need to grow? And it's nutrition, 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 nutrition. If they don't have the proper nutrition, their cognition is not going to be there. They're not going to be growing the way they should because they don't have all the nutrition they need for that brain to be able to work that way. Frequent developmental assessments are important for which reason? Remember when we go to the physician's office or, ER, wherever, first thing we do is height and weight, and then we start looking at what are they able to do, their fine motor and gross motor skills. What are we doing that for? And it's because we can identify delays or deficits early. And why do we want to do that? Early intervention. We want to be able to find out why that child's behind. We want to get that child back up to where they need to be. Children are resilient and they'll pick up quick as long as they get whatever they need, whether it's occupational, physical, speech therapy. Which function of play is a major component of play at all ages? What does play do? It's what we call the sensoromotor activity. We know that their mouths are their major sense of, doing things. Children, we know everything is in the mouth, the touch, the feel in the mouth, and then we play with it and it starts their brain working, being creative, and that's what we want them to do. As much as we don't want those toys in their mouth, it's a good thing for them. The head to tail direction of growth is referred to as. We start with the head, we start picking it up, we start turning over, crawling, creeping, and then we were able to stand up and then we walk. It's called head to tail direction. And it's described there, cephalocaudal. Cephalo is head, caudal is, lower. So cephalocaudal is that sort of growth. Dina's coming up. What is the single most important factor to consider when communicating with children? So if you walk into a child and you don't get on their level, they're not going to do what you want. And you're going to spend 3 times as much more time in there. If you go in, get on their level, start playing with them, you can do anything you want. These children will work with you really a lot easier. And that's the goal. The nurse should expect the anterior fontanelle to close at what age? These soft spots, these children are born with. It's just allow space for that brain to grow, and then it closes. If it closes too early or too late, there's a problem. So we need to know that the anterior fontanelle is 12 to 18 months. Posterior fontanelle is 2 to 3 months. As you do your reading for next week as part of infants, I'm just showing you it's something that you should pay attention to. What 2-year-old child pain assessment tool should the nurse use? What do we use for the 2-year-old? So the 2-year-old is FLAC. FACES is not till preschool, ages 3 to 4. Okay, that's a question that I've seen on NCLEX and on SE. So knowing the difference in pain tools, pay attention to it. At 6 months, an infant's birth weight should do what? Well, we know they grow quick. How much? If I was born at 7 pounds at 6 months, how much should I weigh? And you should double by 6 months, okay? Triple is 1 year. And when you're doing your assessments and you're seeing too much or too little weight gain, that is a problem. We need to be able to know that so we can tell a physician. So what intervention? The first expected fine motor development milestones for an infant begins with. When we talk about fine, we talk about hands. We talk about gross, we're talking about rolling, turning, and walking. So know those things. Fine is always hands. So the first thing an infant does is you take their hand and you put a rattle in it and they close it. Involuntary. It's called a reflex palmar grasp because it goes into the palm. Then it goes into a voluntary, then it goes into a crude pincer grasp, then a neat pincer grasp. Then we could put things in a container and build a block of 2. You're going to see this in the reading. Pay attention to it because these sort of things you will see with they can't do this or that. You need to know that that developmental stage was not reached. That's something that needs to be looked at. Aren't doing a developmental screening on a 10-month-old should expect which fine motor skills? Remember, fine is hands. Fine is always hands. We're going to be repeating a lot of this next week. I'm just bringing it to you this week as an introduction. So by 10 months old, they should be able to grab that rattle and they should be able to at least use their fingers. And I call that pincer grasp as putting those Cheerios on the high chair and they can take like that. At first they take a bunch and smush them. And then in the end, they could take one at a time very, slowly, right? Kinson's back on top. Come on, Megan, go get her. The natural physical developmental sequence that most children follow is what? And this is gross motor skills. I briefly mentioned this. And we start with lifting their head up, rolling over, back to front, front to back, creep, crawl, cruise, and then they walk. This should be done by ages 1 year old, but it doesn't mean that if it went to 15 months like my kids and my grandson, that they're behind, as long as every other developmental milestone is being met. Frequent developmental assessments are important for which reason? Yes, I had the question before. So again, that's because we want to know if there's any delays or deficits so we can do early intervention and get that child caught up. Which behavior indicates that an infant has developed object permanence? Right, that 1-year-old gonna go find that truck in the toy box? And that's because even though it's not in sight, they know it's still there and they go looking for it. Good job. Ashley coming back up. Which developmental theory covers the entire human lifespan? And that is Erickson's, and Piaget is different, but that one is Erickson's. And I'll be sending you the handouts that you can have it. McKinsey's on fire. In general, an infant should triple their birth weight at what month of age? And that's 12 months. Doubles at 6 months, triples at 1 year. Good job. Which intervention is contraindicated for a toddler? Now, a toddler's age is 1 to 3. We know they just starting to walk. By the end of toddlers, they're usually potty trained. Hopefully, not all, but hopefully. So they do a lot of things in that. The problem with being a toddler is some parents expect them to be perfect. Like if they're putting their clothes on and they did them backwards, they're going to say, hey, you know, what happened there? Or they had the shirt inside out. Now, I'm excited they went potty and came back and had their shorts or shirt on, right? It's not that it was on correctly. It's that they made the attempt. You don't want to get this child frustrated or not want to attempt because they did it wrong. So we don't want to do that because, you know, that will, you know, stop them from doing, you know, what you want them to do. Try, just try. And RN assessing a 2.5-year-old toddler should report which finding to the provider? What is not right? So great, because the head should be less or at least equal to the chest at this point. Good job. And if it's bigger than, something's wrong. It could be hydrocephalus, could be brain tumor, could be something else going on. Good job. Which is the best approach when preparing a toddler for a procedure? Toddler, ages 1 to 3. You need to do a blood pressure. You need to take an X-ray. A lot of times is you let them do the procedure on a doll. Let's say you had to start an IV on that child, you know, so you're letting them practice somewhere else so they are comfortable with the equipment and they're not going to be afraid. So number one, getting on their level so that you can explain things to them, and then letting them practice on a doll is going to get them less fearful because they know what's coming next. They know what the equipment is. Perform a head-to-toe assessment on a toddler. Most important to consider before beginning the examination. Again, toddler, ages 1 to 3. Again, get on their level. Perfect. Good job. If you don't get on their level, you know, you usually have a certain amount of time. I mean, I worked in an emergency room, the last part of it, and I had 4 rooms, which means I had 4 children if there was only 1 child in each room. And if I had to spend a half an hour in one room, the other rooms are not getting my attention, and they might have needed that attention. So if I go in, get on their level, get it done, 10 minutes out, I've saved a lot of time. So playing with a kid first, getting on their level, it does work. An RN expects that a child at 6 months age development status will be able to do what? And this is that gross motor skills. So we start with picking their head up. Then we roll from front to back, and then back to front. Then we get on their knees, and then they start creeping, crawling, and then walking. At 6 months of age, they should be able to turn completely over, front to back to front, as a minimum. According to Piaget, toddlers are in the blank developmental stage. When we look at this, we know there's Erikson, Piaget, and Kohlberg are the ones to look at. Autonomy versus shame and doubt, and trust versus mistrust are all Erikson, just by the wording. Piaget are formal operations, sensor, and motor. In toddlers, the name is sensor and motor. Touch, feel in the mouth, play with it, move it around. Megan's up top. Which intervention helps a hospitalized toddler feel a sense of control? You've admitted a 1 to 3 year old child, and they're in a hospital. Now, one thing you're going to learn about with toddlers love rituals, routines, and schedules. When they're not on that schedule, they don't do well. When you become preschoolers, they don't need that as much, but that 1 to 3 year old, they need the same routines, the same foods, the same schedule, the same naps, the same bedtime, the same everything. And then they feel more secure, or that sense of control. All children reach developmental milestones at the same age. All children walk at 1 year old. Absolutely not. Absolutely not. They're all different, unique, and special. And that's why I love pediatrics, because they're all different. They're not like adults. Adults are all the same. Children are not. Immunization for a 4-month-old infant. What action should the nurse take to provide atraumatic care? 4-month-old infant, what are you going to do? I need to give them a shot. And I'm going to do that non-nutritive sucker, the pacifier with sugar water, and it's going to work. Z-Track, no. Aspirin, I never give to a child at all for the fear of Ray's syndrome, except one diagnosis that will later. Parents are always in the room, and Z-Track, it doesn't really matter. It's not going to provide atraumatic care. It's that non-nutritive sucking and that sugar water. Which of the following immunizations can be administered to a newborn? Now, when you get to the reading of the infants, there's a double page of immunizations like crazy. I'm going to break it down and make it easier for you. But the first vaccination that we give, usually at the hospital before they go home, is hepatitis B. So hepatitis B is that first one that we give. Excuse me, Aisha's going up after you, Megan. The normal heart rate for an infant is, I need to give digoxin to an infant, which is normal. We give mics per kilo, we give digoxin to an infant. I take a heart rate and I find out that is 120. Is that normal? And the normal heart rate for an infant is 140 to 160 at rest. It can go to 200 if they're screaming, but 140 to 160 is a normal heart rate. Blood pressures are different, respiratory rates are different, and I'm going to send you that sheet so that you can see that. And that example of using digoxin is one of the questions I've seen used. So very important to know that. A 2-month-old infant has cradle cap. What should the nurse tell their parents to do to treat it? They got, you know, that almost looks like little scabby, crusty stuff. So you're going to wash it normally. You don't have to different sort of anything. You just take a soft brush and just gently do it every time you wash that baby's hair. You do it every night, doesn't matter. And you just slowly, it will get it off. Kirsten's up on top now. What immunizations are included in a DTaP? And this is one of your first immunizations. It's 2, 4, 6 months and 15 to 18 months. So that's your first clue. 2, 4, 6 months is when we start the immunizations, except for Hep B, which is at birth. So it's diphtheria, pertussis, tetanus. And again, you're going to see a whole big list of things. And I'm going to give you a pretty neat thing to, it's a YouTube thing that I found. What is the preferred site to give an injection to an infant? And then we have one more question. You know, the way that that nurse is giving that injection, I would never do that. That is such a liability. She could have hurt that kid. The kid could have scratched, pulled it, hit it. Anyway, it's a vastus lateralis, and I would have given that child a pacifier also. And last question. The death of an infant under 1 year old with no known cause is called what? And this is a whole big project that many hospitals deal with, back to sleep. The children need to be placed on their back. It's called SID, Sudden Infant Death Syndrome. So number 3, Megan, good job, Megan. Number 2, Aisha. And number 1, Kristen. Number 4, Ashley, and 5 is Tippy. Please sign your attendance attestation. Please do not forget that. That will give you a point of reference for attendance, so nothing will happen. You know, that you will make sure that you will be showing up, that you are working in your Canvas, okay? Anybody have any questions, anything you need from me? Remember, holler to me, call out, send me a message, text me if you're having a panic attack. My phone number is on there. I can give it to you again. It's 305-951-8055. If you need me, holler. Thank you so much. Nice to meet you all. And I will see you all in 2 weeks, but I'll be sending you next week's recordings, okay? Any questions, please let me know. All right?
Thank you so much.
Did you
Thank
enjoy
you.
lecture today?
Thank
Oh,
you,
yeah.
Beth.
Thank you.
Good.